Welcome, this is Medicine with Dr. Moran. I'm Dr. Keith Moran. I've made this video on constipation because it's such a common thing that my patients bring up with me. Constipation is generally defined by a number of criteria as you see listed here. There are formal medical criteria which we call the Rome 4 criteria. This was made by the Rome Foundation. These criteria were first made back in 1988 at a meeting in Rome. The Rome Foundation continues to update their criteria, and we're now on the 4th generation. So how do we define constipation? Constipation is defined as any two of the following features: sensation of incomplete evacuation, lumpy hard stools, straining, decrease in stool frequency less than 3 per week, use of digital maneuvers, and sensation of anorectal obstruction or blockage with more than 25% of bowel movements. This is more common as people age. Laxatives are used daily by 10% of older adults and 75% of nursing home residents. Risk factors for constipation include female gender, physical activity that's inactive, certain types of medications, depression, and associated illnesses. This is from Ken Benner at Cartoon Stock. Diagnosis. This is based on your symptoms and physical examination. A review of medications is important. There are many drugs such as narcotics, certain blood pressure medications, antidepressants, iron, some seizure medications, as well as Parkinsonian medications, and they can all be common causes of constipation. You can check side effects for each of your medications that you take to see if there's anything relative to you. If there's a recent change in bowel habits, blood in the stool, weight loss, family history of colon cancer, further evaluation would be important. Please review your symptoms with your physician to see if any blood work or additional tests are required. These are the treatments we talk about. First, review your medications and avoid anything that might be contributing to constipation. Changing behaviors, increasing fiber, and lastly, a trial of laxatives are what we typically do. Behavioral changes. The bowels are always most active following a meal or a drink. This is often the time when stools will pass most readily. If you choose to ignore your body signal, the signals get weaker and weaker over time. Please pay close attention to the signals because you may have an easier time with a bowel movement. An increased fluid intake is often recommended as well as exercise, but actually there's very little evidence to support this. Despite this, physicians typically encourage regular physical activity, and the fluid intake we talk about is 1.5 to 2.5 liters a day, or 6 to 10 cups per day. Avoiding dehydration is certainly important. A regular bowel regime can be attempted. This is what I recommend. Most people with a normal bowel evacuation have a bowel movement approximately the same time each day. This suggests that having a bowel movement is part of a conditioned reflex. The optimal time for a bowel movement is usually within the first 2 hours after waking or after breakfast. One can try to retrain the bowel where you attempt a bowel movement 30 minutes after a meal. Make sure that you make an appropriate amount of time to have a bowel movement. You need to reserve time for that. Do not sit on the toilet more than 10 minutes. Make sure you're sitting upright with your knees as high or slightly higher than your hips. A small footstool can be used if the toilet seat is tall. Drinking a warm beverage in the morning with a high fiber breakfast can also be helpful. Dietary fiber is the edible parts of plants that cannot be digested. It is seen in all plant foods, including vegetables, fruits, nuts, seeds, grains, and legumes. Fiber increases stool bulk, which causes the colon to distend and then will promote stool movement through the colon. A fiber intake of up to 25 grams per day for females and 35 grams per day for a male is often recommended. The effects of fiber on bowel movement can take several weeks. Bloating and flatulence, though, is a common problem with increased fiber intake, and generally one has to do this slowly. Many fruits and vegetables can be particularly helpful at preventing and treating constipation. This is particularly true of citrus fruits, prunes, and prune juice. Choose fruit or vegetables instead of juices. There are many sources of fiber from vegetables, beans, nuts, and grains such as barley, oats, quinoa, whole wheat, bran, and so on. Laxatives. There's a variety of laxatives available for treating constipation. Typically, a bulk-forming laxative which consists of natural fiber is tried first. Products such as psyllium, which is the trade name Metamucil, or wheat dextrin, trade name Benefiber, can be tried. You should always increase the dose of these fiber supplements slowly to prevent gas and cramping which might occur if you do it too quickly. Make sure you take the supplement with plenty of fluids. The dose of psyllium is up to 1 tablespoon 3 times per day with the onset of action in 12 to 72 hours. Stool softeners have limited clinical benefit but are often used. They allow water to more easily enter the stool. They have few side effects but are less effective than other laxatives. Docosate 100 milligrams to 200 milligrams a day is what's typically prescribed as a stool softener. If there's no response to a bulking agent or stool softener, we usually use polyethylene glycol. This is what's used for colonoscopy preparation. A low dose, 17 grams per day, which is typically a capful, is helpful and well tolerated in people. Trade names are Laxaday or Restoralax or Miralax. 17 grams twice a day can be helpful but can cause bloating and cramping. Alternatively, if this particular medication is not helpful, lactulose is another over-the-counter option. Generally, it tends to be a little less effective than polyethylene glycol. And of course, it should be avoided in diabetics because it has a high sugar content, which you can taste. Stimulant laxatives such as Senna, or otherwise known as Senocot 8.6 milligrams orally, or Bisacodyl 10 milligrams orally, can be helpful on an as-needed basis. They work in about 6 to 10 hours, so taking them at bedtime, then having a bowel movement in the morning is typically how they would be taken. Both of these stimulant laxatives can lead to low potassium levels, and the long-term safety of these medications have never been studied. I tell my patients to use these only as needed. Senocot in particular can cause dark pigmentation of the colon, but it's not known to cause colon cancer or other colonic problems. Now, there are narcotic blocking medications which can have a role in the treatment of constipation that's induced by narcotics. This can be quite helpful for people who have cancer who need to take their narcotics. Obviously, tapering and discontinuing the narcotic is preferable, but you can't always do this in certain situations, particularly in situations where someone has cancer. Thank you for watching this video on the treatment of constipation today. If you suffer from this problem, I hope some of my advice will be helpful to you. I'm Dr. Keith Moran. Get healthy and stay healthy.